evening. It's been a long time since I've been up here, so bear with me. So a little about myself. Let's see, started out general practice, actually. Wanted to try that before I went off into the academic world. Adopted a internal medicine residency, went out to Washington State. And then while there, strange things happened, and I also did a concurrent medical oncology residency. Came out, finished it up at the University of Missouri because Carolyn Henry had the temerity to move down there. Finished that up, went in, and I've been around practices, Midwest, once out in Boston. Most recently, I was in St. Louis, doing both medicine and oncology. Had the opportunity to come out here to New Jersey. A lot of people say, oh, why are you in New Jersey? Well, great place to work. NorthStar's been wonderful. Huge shoes to fill, Dr. Barber. And it's been wonderful. And so I'm excited to be here. Just started in February, so just still getting my feet wet and looking forward to meeting all of you people. Okay, a little louder. Tammy, a little louder. You can hear. Okay, you say louder. All right, I will try and talk in a deeper, louder voice. All right, so tonight we're going to go focus on medical oncology, more than just chemotherapy. And let's see if I can remember how to do this. Aha, wrong one. Let's go this way. So we're going to have a brief review on cancer, very brief. And then we're going to talk about options for treatment that are not surgical, not radiation or integrative. Got other people for that. What is cancer? So we have to decide what and define what we are working against. So we got these cells, they're unregulated. They're growing too fast. We have too many of them. And yeah, I am just need to settle down here. Biggest problem that we tend to run into, and what a lot of animals are euthanized for, a good portion of our population, is metastases. And that's a failure on our part, and we're working hard every day to get a better understanding of it and also better ways to fight it. Definition, what happens in metastasis. Just going to skip it, sorry. Let me take a minute. All right. What can we do to fight it? Let's just get into the nuts and bolts. We have our mainstay, which is surgery. The surgeons are always going to be there for us. We have chemotherapy. It's been around a long time. We're constantly honing and perfecting our techniques and our ability and the choices that we make, and also the agents that are available to us. We now have targeted therapy. We have immunotherapy, radiation therapy that Dr. Chetney is going to talk to us about, as well as integrative medicine, which Dr. Shapley is going to talk to us about. What is chemo? In the old school, it was any drug we were sticking in the body to fight cancer. Now we're talking drugs that kill rapidly dividing cells. We have primary chemo. We have adjuvant chemotherapy. Primary, such as we use for lymphoma, multiple myeloma, or metastatic disease. Lymphoma has been our mainstay. We all know about the CHOP protocol. We've been using that for a long time. We now have a game changer with the LOP protocol. As far as treating the T-cell lymphomas, we're doing a lot more with flow cytometry. We're identifying B versus T, which has made life a lot easier for all of us, not having to do the immunohistochemistry. And the invention or the adoption of the LOP protocol has made things a lot, leveled the playing field as far as the T-cell and their survival times. Adjuvant therapy, we all know that the osteosarcomas do a lot better. Hemangios do a little better, as well as mast cell tumors, high grade. So definitely a good place for it after the surgeon has done their thing. Metronomic chemotherapy. So we're doing low dose chemotherapy uninterrupted for a long time. We think that it has an anti-angiogenic mechanism because the endothelial cells are more sensitive. Typical agents that are used have been chlorambucil, CCNU. I'm not much of a Cytoxan person due to the side effects, and often used in combination with the NSAIDs. Newest ones out there, or new ones out there that have come in and have been a nice addition to Novia. Robaxocidine, recently introduced and quickly adopted. Starts as a prodrug and interferes with the DNA synthesis. It's given over 30 minutes via infusion every 3 weeks. Wonderful drug. However, you do want to limit the number of times that we give it, just like doxorubicin with cardiotoxicity. The pulmonary fibrosis that you run into if it becomes a toxicity is horrific, and it comes on very quickly. Obviously, Westies are a breed that we would be very, shall we say, we'd have to think twice about using it in. But it is great. You get an overall response rate of 73%, even in these dogs that have seen multiple drugs. It's a great thing to have in your arsenal. Still trying to work it into primary protocols. We'll see more work on that. One of the bigger drawbacks, it's a new drug. It's costly. Another drug out there, Laverdia. I don't know where the slide went. Works by exportin, blocking it. I have not been as happy with it. It's a wonderful change of pace. It's oral. It's given twice a week. Had my personal experience with it, although it is generally accepted by the client, had a lot of GI side effects with it. And it's just not near as effective as Tanovia, but definitely something that's very easy. Another option for the client that isn't going to want to do the IV drugs. Targeted therapy, rapid growing area. All sorts of targets that we can go after. Epidermal growth factor, the HER2, platelet-derived growth factor, all coming up. Many things that are active areas of research that we can specifically target on these cells. Instead of going after the rapidly dividing cells, we can find that receptor, hopefully knock that out, or multiple receptors as we found with Palladia, and functionally knock out the cell telling the tissues to do something, most often angiogenesis. The multi-kinase receptors we're all familiar with. They target multiple of the tyrosine kinase receptors. Most common one we know, tosarenib. If I'm one behind, all right. And so not only are we're blanketing multiple, so it gives us a better chance of affecting the cancer. Dasatinib is another one, targets a different group of receptors. Palladia, we've had out for quite a long time for mast cells. It's been around for a long time, but it has multiple indications. All the carcinomas are susceptible. Chemodectoma has been a cancer that it has been shown to be very effective against. Stromal tumors, anything we can throw at inflammatory mammary carcinoma is a plus. Nasal carcinomas, thyroids as well as TCCs. The side effects, obviously gastrointestinal are the most common. Diarrhea can be fairly intractable at times. Myelosuppression, watching the white count, hypertension, proteinuria, as well as muscle pain. I've only seen it once. It was horrible, but it went away very quickly. Dog could barely walk. Hair and pigment changes, they can be very bizarre. One dog turned a greenish hue. Immunotherapy has been another very active area of research. We all have seen the melanoma vaccine Oncept has been out for now quite a few years. A new one being studied with the GD3 antigen. Very well tolerated. Initially, the Oncept numbers were quite good. However, recent research has shown that maybe it's not quite as effective as what we once thought. However, it still remains one of our best and most effective agents against melanoma, besides radiation and surgery. Osteosarcoma, we've had the recent Listeria vectored vaccine that's been showing very promising results. And we're working on some lymphoma plasma-based vaccines. Elias has had a very nice adoptive cellular therapy with CAR-T cells created by taking our tumor tissue and we're making a vaccine out of them. We're harvesting those T lymphocytes, amplifying them and putting them back into the patient along with interleukin 12, and that has been shown to be very effective, with average survivals coming out in about greater than 730 days. Another thing we're looking at, which has been a huge area, has been the tumor microenvironment. It's always been not a mystery, but we've always tried to understand why the immune system is not helping us out more, and the tumor microenvironment has been a big part of this. And the unmasking of the cancer cells to both our chemo agents as well as our native immune system has been an area of active research. We've looked at the liposomal clodronate, so that depletes the tumor macrophages, bacterial superantigens, and this one certainly that we've been instituting the use of losartan for monocyte migration inhibitors has been producing increased survival times, as well as a blockade of the CCR4 with an antibody. So a lot of things going on, a lot of research that is just coming out to fruition, that we're going to see more and more of the results, and we'll be able to implement it in our day-to-day oncology practices, as well as the checkpoint molecule immunotherapies. So in the immune system, we want it to work for us, but we don't want it to do too much. We need a stop, and that stop are these immune checkpoints. So we've been targeting these as another potential area to say, let's keep the immune system working for us, and we're developing antibodies, anti-CDK9 PD-1 and PD-L1. So another area where we're trying to unmask the tumor and let the immune system help us. Dr. Sanchez was here. She could talk to us a lot more about virally vectored delivery, specifically brain tumors. She's on our staff taking her boards right now and worked with the Newcastle virus. We also have seen adenoviruses for brain tumors. Um, Nanoparticle interleukin 12 for soft tissue sarcomas. Um, Salmonella, um, a lot of areas trying to come at the cancer more than just with our old chemicals. Torogen is another way of producing a vaccine. Little, just by basically taking the patient's tumor um, and exposing it with small intestinal submucosa to hopefully activate the CD8 cytotoxic T cells. Um, Still generating data on this one, but it's another area that we're looking at. Stelfonta, uh, another way that we're using immunotherapy for mast cells, potent signaling molecule, works by a variety of mechanisms, has been developed for mast cell tumors. It's been very effective in those non-resectable mast cell tumors. Um, However, you do definitely want to pre-medicate these guys with the H2 blockers and the H1 blockers. The very first one that I used was on a sub-Q, just down in the metacarpus. And even though he was well primed with all of these, had a huge hyperhistaminic response. So ended up in the ER. So that was my very first Stelfonta memory. It has gotten better since then and is very useful. 87% effectiveness with 2 injections, 75 with 1 injection. The map on where it's recommended to use them for the subcutaneous, below the hock, below the elbow, cutaneous, pretty much anywhere on the body. Certainly have to think long and hard on bypassing the surgeon for this one, but it is a very viable and wonderful new addition. Just some pictures. You have to warn their clients definitely that there's going to be a big hole in their dog. However, it is amazing how quickly and rapidly that disappears and how efficiently that the body will repair itself. So yet another good addition to our non-chemotherapy. And finally, the liquid biopsy. We've always had as the holy grail. Take a blood sample and tell you if you've got cancer. We've all been asked this, and it is starting to come to fruition. Basically, what we're doing is taking a blood sample, looking at cell-free DNA of a specific tumor type, and isolating it and saying, you shouldn't be there. The cancer's gone. Or, I didn't know you had this. You have cancer. Especially in those cases where you've taken the tumor off, you want to know, do I still have microscopic disease? Is there still disease in there that I can't see? And that's where always this has been the potential to open up that doorway to say, am I missing something? Should we be going further? Should I be doing more therapy on this dog? And that's where we're going to be seeing this as a very potential, as hopefully a very useful agent. However, the problem is the sensitivity of it. I mean, the work was done in basically very dramatic cases. So we're going to be seeing a lot more on this. We see it. It's on the radio. It's being proposed for us. Get your cancer screen. The DNA only lasts for up to 8 hours in there. So then it's cleared. So, and you're still sampling a very small, it's a needle in the haystack. You're just getting a very small sample out of a big body. So we're going to need a lot of work on this, but it holds a lot of potential in there. And we do have some good veterinary products out. They're going to get better and better, I think, is my functional bottom line. But this is one we'll want to keep watching very closely. questions after that terrible talk?